Yes.
All right, well, welcome everybody. For those of you that know me, my name is Sean Toomey. I'm the Director of Strategic Partnerships here at Inspire MSCRO. Welcome to those who have never been here before for the first time. Inspire MSCRO is a licensed assisted living and memory care community. Just a little bit about the community. We're obviously an elegant, beautiful building in a gorgeous city, urban setting. We have 174 apartments, 45 of which are licensed for memory care. So those are secure and safe. They have a different level of staffing and a different programming, different level of programming. It's an adaptive programming product. So what we try to do since we opened 6 months ago is to open our doors to our neighbors in the community and to become a hub of information and education, a place where you can come and get inspiring lectures on a myriad of different topics, including health-related topics. And this is a really critical and really topical topic today. We're going to talk about brain health. So we have two leaders here from Sunday Health. Sunday Health is a modern cognitive care practice. We have with us the CEO of Sunday Health, Maria Thomas, and Maria is really driving the innovation of Sunday Health. She's working to make more accessible, early detection, being proactive about supporting folks with brain issues, and is really trying to make a change in opening the accessibility to it. It can take 6 to 9 months to make an appointment with a neurologist these days, I've heard, and Sunday Health is working to change that. And so it's a really innovative thing these days. In addition to that, they've partnered with experts in the field to expose their patients to cutting-edge treatments as well as clinical trials. So we're really thrilled to have Maria here with us. Joining her is Dr. Amy Sanders, and Dr. Sanders is a dementia neurologist. She's got over 15 years experience in clinical and academic settings. She's led Alzheimer's research and been published extensively. And my understanding, I haven't seen this talk, is that she's able to take these complex neurological topics and issues and make them much more manageable for us. So when I thought about this introduction, I thought about driving innovation and expertise, and I think we're in for a real treat today. So without further ado, Maria Thomas, Dr. Amy Sanders. Thank you. Yep.
Good afternoon.
You weren't on.
Oh, yeah, sorry.
Yeah.
Oh, are we using my mic, Ahmed? Do I need this mic?
Yeah.
Okay. Good afternoon, everyone. Thank you so much for joining us. Two things based on what I just said. First of all, we're delighted to have Ahmed with us in the back. He's videoing this presentation because there are some folks who wanted to attend but couldn't attend, so we're archiving it for everybody's benefit. So please know that the whole presentation is being recorded. Secondly, I just heard someone's cell phone. Could you please turn off your cell phone ringers so that we don't get that into the video, which would be disruptive. Now, with those housekeeping issues out of the way, let me welcome you and please thank Sean and Inspire for hosting us at this amazingly beautiful building. And I've had the opportunity in the past to tour it and to see the residences. It's really just an incredible community and wonderful resource to be able to host events like this to help educate and share what people like experts like Dr. Sanders know. So to get us started, I have a few questions for all of you. How many people, if you're 50 years old or over like I am, how many people knew when you turned 50 that you're supposed to go get a colonoscopy? Yeah. Most people know that. How many of you go to the dentist at least once a year? Yay, oral health, wonderful. Women, question for all of you. Who gets a regular mammogram or has in the past gotten a regular mammogram? Friday. Men, same question. PSA, prostate exam. Some of you, okay, maybe we need to do some work on that. Okay, next question. How many of you have gotten your brain health check, regular annual brain health check? Oh, good group here. Love it, love it. Okay, well, that is a little exercise designed to help open up the dialogue of what we're really all about at Sunday Health. So as Sean mentioned, my name is Maria Thomas. I live right here in DC. I am the CEO, but not a clinician. I am the CEO of a group called Sunday Health. We are a specialized care practice focused exclusively on cognitive care. Cognitive care, that means memory and thinking. And we are right now operating in DC, Maryland, and Virginia. We are a relatively new, but not brand new organization. We've been around for about 2 years. And one of our big ideas here is to elevate the idea of proactive brain health. So the reason I asked you all those questions is that somehow in the United States, we've kind of gotten our heads around the idea of preventative health for, screenings for cancer or, our oral health or whatever it may be. We all understand that there are certain things we can do to stay healthy in different areas of our body. We need to remember that for our brain. And so here at Sunday Health, we're really trying to elevate the idea of proactive cognitive care, and you'll hear us talking a lot about that today. So the way we're going to do this is I'm going to give a little bit more introduction to Dr. Sanders. She and I are going to have a dialogue about some basic, make sure we have a level setting, get into some of the new things that are happening in this arena. When I say this arena, I mean cognitive care, dementia care. We're going to talk about some of the new blood tests, some of the new drug-based therapies, and very importantly, about non-pharmacological interventions. And then we'll open it up for questions from all of you and from our online audience. How's that sound? Great. Okay. Well, I like when I see nodding heads, and I know you're awake. Stay with me, everybody. Dr. Sanders is a real expert, as Sean said, in dementia neurology. She's been practicing since 2008. She got her medical degree from Albert Einstein College in the Bronx, where she was also a tenured professor. She's also had a professorship at Upstate University in New York, and most recently, before joining us at Sunday Health, was a founding clinician and leader at the Ayer Neuroscience Institute at Hartford Health in Hartford, Connecticut. And Dr. Sanders does live in Connecticut because at Sunday Health, we provide care both in person and via telehealth. And we'll talk more about that and how that works if you're curious about that. So welcome, and hello, Dr. Sanders.
Hello, Maria. And can people hear me all the way in the back? I have a really loud voice, so I'm just
Ahmed, do you want her to use the microphone?
You want me to use the mic?
Yeah.
Okay, all right.
And I think you have to turn it on.
The on-off mode selector. Testing? No. Testing? Oh,
Yeah.
yes.
Okay, great. Well, hello.
Hello.
Yes, nice to be here with you. So we like to start usually with some kind of definitions, if you will, just to make sure that everybody's operating with the same language. And then we can communicate, which is useful. So, Dr. Sanders.
Yes, Maria.
What is the difference between dementia and Alzheimer's disease?
Before I answer that question, and I love to answer that question, I'd like to see a show of hands. How many people believe that you know the answer to this question?
Ooh,
How many people believe you know the answer to the question? What is the difference between Alzheimer's disease and dementia? Okay, I am now going to tell you what I believe is the difference, and then I'm going to want to see a show of hands again. Be honest, were you right at the beginning? Because, why am I setting it up this way? You would be surprised, or maybe you wouldn't be surprised, at the number of people who do not understand that these are not interchangeable terms, they are very much related terms. Dementia, the word dementia, is nothing more than a catch-all term, if you will, an umbrella designation for the situation where somebody has cognitive impairment that has become significant enough that it is now beginning to impair a person's ability to live their lives in their usual way. Maybe they get lost when they're driving in familiar places, and so they no longer can drive a car. Maybe they no longer can manage their own money or manage their own medications, or perhaps they no longer are safe to use the kitchen. There are all sorts of different ways that function can decline as a consequence of impaired thinking. And that is all dementia means. Dementia is nothing more than impaired thinking that is causing an impaired ability to function in one's daily life in the usual way. Alzheimer's disease is the big granddaddy of the diseases, or grandmommy. I don't want to be, gender biased here. Alzheimer's disease probably accounts for some 60 to 70% worldwide of cases of dementia. Dementia is a syndrome. It's just a collection of symptoms. I told you what the two symptoms are: cognitive decline, functional decline. That's all dementia is. When I tell somebody, I think you might meet criteria for dementia because your thinking has declined and so too has your function, the next sentences out of my mouth had better be, why do I think they have this dementia? What disease is causing the dementia? Alzheimer's disease, 60 to 70% worldwide of the cases of dementia. I think of three other conditions as sort of rounding out, if you will, the big four. There's dementia with Lewy bodies, what Robin Williams famously had. There is vascular cognitive impairment, or vascular dementia. The only dementia that is not neurodegenerative. You get it as a consequence of having strokes, but if you can prevent yourself from having another stroke, you may be able to retard any further cognitive decline. And then the frontotemporal lobar degenerations, which is a handbasket of multiple different conditions. Bruce Willis famously has one of those. So those are the big four dementing diseases. Dementia, just a catch-all term that describes the state where cognition has begun to fail to the degree that it is now impacting a person's ability to take care of themselves fully.
Yes, ma'am.
And how many of you got it right? Most of you did. Very good.
So we
This
can
is
go
clearly
fast.
the advanced class.
We can go faster with this class,
Yes.
for sure. But we have a question that we'll go ahead and take, please.
Can I ask my question?
Yeah, of course.
Yeah. In talking to the doctors, they're classifying dementia as part of dementia being one of Alzheimer. Is that true? Is dementia considered an Alzheimer?
I think just to repeat the question for people online, the question is, I'm going to paraphrase a little bit. The question, I think, is still a little bit about the difference between dementia and Alzheimer's, or is Alzheimer's dementia? Is that what you're asking?
Yes.
I think what Dr. Sanders was just saying is that Alzheimer's is a disease, is a dementing disease. So if you think of dementia as the umbrella term, Alzheimer's is a disease that is under that umbrella. It is the largest, 60 to 70% of the dementing diseases. So yes is the short answer.
It's not the other way around, because I always thought Alzheimer and then dementia.
No.
So it helps, I think, sometimes to reason by way of analogy to cancer. Cancer is also a syndrome. It's a syndrome caused by some cluster of cells somewhere in the body proliferating way more than they should. So if you hear that your next door neighbor has cancer, typically, what's going to be the next question out of your mouth? What kind? Exactly right. Same reasoning should apply when dementia comes up. If you hear that your next door neighbor has dementia, the next words out of your mouth should be, what kind? And so then you would want to know, is it Alzheimer's disease? Is it vascular dementia? Is it dementia with Lewy bodies? One place where it does occur to me that sort of confusion lies in the nomenclature itself is that sometimes people call Alzheimer's disease Alzheimer's disease. Sometimes they call it AD, which is just the initialism for Alzheimer's disease. And sometimes they use a term called AD dementia. And that's usually when somebody wants to distinguish between a clinical state of dementia, cognitive decline, functional decline due to Alzheimer's disease. They want to distinguish that from earlier stages of Alzheimer's disease, because also what we know is Alzheimer's is not a binary all or none phenomenon. It is increasingly now, too, we understand it to be a continuum of disease. It goes everywhere from preclinical disease, which means that you have something that maybe we found in a blood test, but you have no symptoms, to symptoms involving cognition but not function, and then symptoms involving both cognition and function. So the terminology itself can be somewhat unhelpful here.
So let's just extend that one more area. Dr. Sanders, you mentioned the continuum. What's mild cognitive impairment, or MCI?
MCI is itself a diagnosis. There are diagnostic codes that I can enter into somebody's chart for mild cognitive impairment. Please hear the capital M, the capital I, the capital M I can spell, the capital C, and the capital I. When we use it in that phrase, MCI, we are defining a disease entity. If we have a lowercase m, c, and I, then we're really sort of using it in a descriptive way. Always, mild cognitive impairment lies somewhere between normal cognition for age, and cognition changes as we age. So a 35-year-old's cognition is going to be measurably different from a 75-year-old's cognition. So if we say that somebody is normal for age, we are saying that about a 75-year-old who is similar to other 75-year-olds, not necessarily similar to 35-year-olds. That probably wouldn't be a fair comparison. But similar to other 75-year-olds, you're good to go. And then if somebody has at least one area of thinking where there is objective evidence of impairment, that means you have been formally tested. Most people don't realize that. Many physicians don't realize that. But you need to have some sort of formal testing that demonstrates an objective impairment in at least one type of thinking. If you just come to the doctor's office and say, gosh, I really am worried about my memory, that is not an objective impairment. That is a subjective impairment. You are subjectively saying, Doc, I think that my memory is shot. If I then test your memory and I find that there is a memory problem, then there's also an objective impairment. MCI requires an objective impairment in at least one type of thinking, but no functional decline. Does that mean that you have to do everything with the same skill and alacrity that you did things when you were 20? No, not necessarily. We recognize that, as a person ages, their ability to do some things gets better, and to do other things may take them a little bit longer to do things than it used to. The trick is, you can always get there in the end. Might take longer to learn a new task or a new skill. You can learn it in the end. You're probably functionally intact, and that's okay for MCI, not okay for dementia.
So, Dr. Sanders, are you saying that should the group understand that cognitive decline is or is not part of normal aging?
Yes. So, the way that we think changes as we age. I just mentioned one way in which that happens. It takes us longer to learn things. We can still learn them, it just might take us longer. So the example I used to give was, can you program your own VHS? So I'm showing my age there, right? Because when was the last time anybody in this room had to program a VHS? So once upon a time, that was a big challenge. I now, when you have to get a new smartphone, how long does it take you to convert? That is a non-trivial undertaking. Do not for one second think that it is not. I once attended a talk where somebody threw a slide up, a very, very famous dementia researcher threw a slide up with, that basically said, this is not your grandmother's Medicare. And just wanted, to underscore, at that time, this is 20 years ago, how many changes were occurring. And that's happening in dementia medicine now. Sorry, that might have been a tangent. So, as we get older, our brain does change in the way that it functions. Famously, anybody in here ever not be able to find the word they want in the moment that they want it? The name of that book, that restaurant that we went to, that actor's name, even just a verb. So, if that happens to you, and whatever was lost is found, comes to you in seconds, minutes, hours, days, or once very memorably for me, 6 months later, I'm not kidding, that we call the tip of the tongue phenomenon. In the vast majority of cases, that is not pathological. It is normal for cognitive aging. This is not to suggest that it is not irritating and aggravating, because it is absolutely both of those things. But it should not make you think, oh, is this the beginning of the end? Almost certainly it is not. And if you then just sort of let your brain relax, put it on the back burner, figuratively, you may find that seconds, minutes, hours, days, 6 months, it does pop back into your head. So that's the tip of the tongue phenomenon. There are many other examples that I could give you of things that are normal for the aging brain. What is never normal for the aging brain? Memory loss. If we were having this conversation 30, 35 years ago, I would probably be describing to you something that we might have even used the word senility to describe. That memory loss was an expected and normal feature of cognitive aging. We know better now. It ain't that. Memory loss is never normal. So if you are having memory loss, if someone you care about is having memory loss, please do urge them to get evaluated. It's very important, and there is a lot we can do to help.
So when we talk about getting evaluated, what does that even mean? What are we talking about? We've mentioned testing here. I know a number of you raised your hand when I asked about, have you had your brain checked? I assume you have been, that's been part of your annual wellness visit. But maybe we could elaborate a little bit on what we're talking about when we speak about an evaluation. First of all, what are the tests that we're talking about, and when should someone be tested?
So, am I there? Yep. I like to say that the best time to start thinking about your brain and paying attention to it on a regular basis is probably when you're in your mid-30s. I'm going to go out on a limb and guess that that's probably a lot younger than a lot of you expected. Why do I say that? Well, it takes probably at least until the mid-20s, probably even a little bit later than that, for the brain to achieve full physical maturity. This is why when people are still teenagers or maybe in their early 20s, they perhaps don't make the best life decisions. The brain is not yet fully mature physically. By the time that we're in our mid to late 20s or our early 30s, it is fully physically mature. And then I'm going to tack on 3 to 5 years for life experience that by the time one reaches one's early 60s might become the foundation for later life wisdom, or so I devoutly hope. Once we are 35, things do begin to change, and this process of cognitive aging begins. And so that is probably the best time to start paying attention. Absolutely, if you have grandchildren, suggest that they start doing it even earlier than 35. There's no way that you can start paying attention to your brain too early. It's also true, it is never too late to start paying attention to your brain. So, Preclinical disease, mild cognitive impairment, mild stages of any kind of dementia, moderate stages of any kind of dementia. There are things that a physician like me and a practice like Sunday Health can do to help. Many people often think, I don't want to go to the doctor, I don't want to find out, because nothing can be done. Nothing could be further from the truth. And if you leave here today taking only one take-home message home to treasure with you for the rest of your days, let it be that one. There is always a way that we can help.
Thank you for that, Dr. Sanders. So one of the reasons why we formed Sunday Health is that there's a lot happening in the arena of cognitive care right now. And when I say a lot, some of you may have heard of some of these things, but we have new blood tests that can be used for diagnostic purposes. We're going to talk a little bit about them. There, in the last just 3 years or so, have been 2 new FDA-approved disease-modifying drug therapies. So these are disease-modifying, not drugs that just address the symptoms. There has been a mountain of research, including most recently just at the Alzheimer's Association International Conference last month, a new study out called the Pointer Study. And this mountain of research, including the Pointer Study, really grounds us in the importance of lifestyle factors and their impact on our brain health. When I say lifestyle factors, I mean things like what you eat, whether you're wearing your hearing aids if you need them, whether you're socializing. There are many of these factors. We call them modifiable risk factors. So when Dr. Sanders says it's never too early and it's never too late, there are things that we can do and that we at Sunday Health embrace, and we're going to talk about those things now. So let's start with these modifiable risk factors. There's a lot of research in this area. If you're the kind of person who enjoys reading the research, you can refer to the Pointer Study, just like it sounds, Pointer Study. A year ago, there was a study out from the Lancet Commission, LANCET, which specified these modifiable risk factors. So this is not Sunday Health. We incorporate this into our care model, but this is scientifically grounded, validated research that we're incorporating. So turning back to you, Dr. Sanders. So when we talk about these modifiable risk factors, maybe we could start with what's modifiable and what's not modifiable.
So, what's not modifiable, that's pretty easy. Things you cannot change. So, who your parents were, which is another way of saying what your genetic makeup is. Many of these diseases have some genetic dimension to their natural history, but are not exclusively genetic diseases. And that varies by dementing disease, but so you cannot change your genetics. Now, if there were any geneticists in the room? Okay, good. So I don't need to talk about the phenomenon of epigenetics, which suggests that in fact you can change your genetics, but not in the way that you're thinking. So you cannot get in the Wayback Machine or a time machine and go back and change where you went to school, how well you did in school, and who you went to school with. You cannot change. I saw a brow furrow back there. Why do we care? Why does education matter? Education is recognized as being a protective factor. So I went to college, then I went to graduate school and got a master's degree, and then I went to more graduate school and got another master's degree, and then I went to medical school. I was a late bloomer. So I did a lot of going to school, and that probably stands me in good stead. I use my brain every day when I go to work. I'm fortunate to have an occupation that is cognitively stimulating. I saw knitting needles What is knitting? What do knitting need? Do they wave? I see knitting needles in the background. Knitting is a cognitively stimulating activity. So there are many activities that are cognitively stimulating. There are many things that we can do for our brains that are good for our brains. So knitting helps to, on the theory of use it or lose it, knitting makes you use your brain. That is good for your brain. It's brain exercise. If you exercise your body, that's also good for your brain. It's just a slightly different kind of exercise. Exercise what you eat, what you drink, what you don't eat, what you don't drink, how well you sleep. Are you happy? Are you depressed and anxious? All sorts of factors where you can decide, I'm going to do something a little bit differently. For example, I am not actually card carrying anymore, but a confirmed Coca-Cola addict. And I'm not talking the diet stuff. I'm talking the full-on 100% sugar. When I was in graduate school, I could drink a 6-pack of this stuff a day. About 15 years ago, the research started coming out about just how bad soda is for us. The sugary stuff, probably even worse of the diet stuff. What we didn't know then, and we do know now, is that soda was really the leading edge of the ultra-processed food problem. I now have a Coca-Cola. I have not given them up. I will never give them up, but I have one maybe once a month. What seldom is wonderful. It's a treat. I have modified myself. With the exception of the other night, I very rarely eat potato chips anymore because that is a pernicious ultra-processed food. Simple examples, little changes that we all can make every day. Not every day is going to be perfect. Some days are going to be better than others. We are all works in progress. The idea, though, is that we have forward motion toward the goal of good brain health.
Yes, ma'am.
So I see uncorrected visual impairment up there. Could you say just a couple of words about that?
Let me just repeat the question. She sees on the slide a modifiable risk factor of uncorrected visual impairment, and could Dr. Sanders elaborate?
Sure. If you need glasses, wear them. Mm-hmm. If a lot of people have issues with cataracts, it can be very beneficial to get your cataracts, if not fixed, attended to. So be sure that your primary care practice is aware of any eye issues that you may have. And if you have any eye issues, be sure that you're paying attention to them. Dry eye, you got to use drops. If you have glaucoma, different drops. And then most people, certainly I'm this way, if I'm having trouble with my vision, I am on the phone to my eye doctor yesterday. People don't seem to react the same way, though, when their hearing starts to go. Lots of loud televisions, especially in my house. Untreated hearing loss, we now recognize as one of the most impactful of the modifiable risk factors for cognitive decline and dementia. I believe that we are much more likely to prevent these terrible diseases than we are likely ever to be able to cure them. In fact, here's a statistic. If everybody around the world collectively worked on all their modifiable risk factors, we could probably prevent up to 40% of the worldwide burden of dementia. Wow. We got to get busy.
So that's why we're spending so much time on these modifiable risk factors. At Sunday Health, we really want to take a preventative approach, and we will see folks who have subjective cognitive decline of the sort that Dr. Sanders mentioned. We will see folks who have actual experiencing symptoms and don't quite know what to make of them. Maybe you're concerned because you have a family history. Those are all the types of patients that we see and that we can assess and provide a brain health baseline. We also have, in addition to Dr. Sanders, we have another cognitive neurologist, nurse practitioners. We can help you with the diagnosis. And most importantly, I think, is beyond that, the ongoing care. And when we talk about ongoing care for cognitive issues, oftentimes we are talking about these sorts of things. And I know, because I'm an older adult myself, I know it can sound like, oh, so now you're going to tell me to eat right and exercise. Well, yeah, somewhat, but we're going to try to be more specific about that. So if you tell us, hey, you know, I'm Maria, and I have some trouble sleeping, and also I have a little trouble out of one ear, that might be very different from Dr. Sanders, who, you know, already confessed to her various food addiction. So we're going to try to have an ongoing dialogue with you. Think of it like, you know, when you're trying to exercise your body, you may do that by going out for a walk on your own or with a friend. You may do it by going to the gym and working on your cardio or working on your balance. You may hire a personal trainer. You may go to a physical therapist. There are a lot of paths to the same goal. The same thing is true for your brain. And so we want to try to instill this idea of, you can call it cognitive fitness if you want, if that helps. But it has to do with all of these things. We are going to talk about drug therapies as well, but we really want to elevate this idea that these modifiable risk factors are critical to your brain health. Never too early, never too late. Yes, ma'am?
Could you say a bit about tinnitus?
Yes. And can you repeat the question?
Tinnitus.
Yes, so we have been asked to comment briefly on the phenomenon of tinnitus. So tinnitus, translated, is simply ringing in the ears. And boy, you want to talk about something that is irksome. Many people find tinnitus to be pretty irksome. And tinnitus is sort of neurologically adjacent. It's really in the sandbox of an ear, nose, and throat physician for the most part, at least in my experience. There are some physicians actually, and this is, if you have tinnitus, this is what I would look for, is what is called a neuro-otologist. O-O-O-T-O-ologist. O-T-O meaning ear. And a neuro-otologist may have an audiologist in the office, and they would also have additional things that they could do to help characterize the tinnitus, and then sometimes medications can help. Tinnitus can be pretty irksome. It can also interfere with sleep.
So don't leave before you tell me some of the names that
Okay.
I could send you to one in Connecticut.
Well, we can help you. We can help you with that. Yes, ma'am, please.
Maybe this is a bad time to ask, but can you say something about cerebral small vessel disease and its prevalence and diagnosing it and what you do?
Can I just maybe punt that for a little bit later in the talk, because I want to make sure we have time for talking about the new drug therapies and the new blood tests, and then when we open for open Q&A, you can bring that question back. Is that okay? So I just want to kind of summarize. We have defined the difference between dementia and Alzheimer's. We've defined mild cognitive impairment, and we've talked about the importance of modifiable risk factors and the importance of getting a brain health baseline. So let's say you come to Sunday Health and we need to do a diagnostic pathway with you. We need to determine, do you actually have a condition that can be diagnosed? So one of the things that's very exciting that's happening in the field right now is that there are new tools available to help with that. I'm going to ask Dr. Sanders to talk a little bit, please, about the new blood-based biomarkers. Blood-based biomarkers. Maybe start with what a biomarker is.
Right. So has anybody ever had the diabetes test called the hemoglobin A1C? Yes. Anybody ever have a baby who had an APGAR score?
How about blood pressure?
Yep, blood pressure is another one. So the APGAR is probably the first lifetime biomarker that any one of us encounters. And it is a grading scale developed by a neonatologist, I presume she was. Virginia APGAR was her name. And it just looks at how healthy a baby looks when they initially come out of the womb. And that is a biomarker. It is a physiologic dimension that is measurable. That's really all biomarker means.
Something very simple like blood pressure, your
Yeah.
temperature.
Your
These
temperature,
are
your heart rate.
biomarkers.
All your vital signs are biomarkers. Whether you are in pain is considered to be a kind of biomarker. Any kind of imaging result. In many cases, genetic results. Especially genetic results if they are being looked at to determine whether or not you're likely to respond well to a particular medication. That's a biomarker. Increasingly, in Alzheimer's disease, more fully advanced in Alzheimer's disease than in some of the other dementing diseases, but we're working on them in the other dementing diseases as well. An array now of blood-based biomarkers, blood tests. So, if you have a choice between going to the commercial lab down the street, sticking out your arm and having somebody draw blood, or having to go to the interventional radiology suite where you'll have to lay on your stomach so that the radiologist can put a needle into the lower part of your back and withdraw fluid from around your spinal cord. Which of those two things do you think is going to be easier and more pleasant to get? The blood test. This is huge. So for a long time now, we have had fairly sophisticated ways to see, if you will, the pathology of Alzheimer's disease in a living person. Famously, in my kind of medicine, we cannot make a definitive diagnosis of Alzheimer's disease or any other kind of dementia unless we have brain tissue to look at. That means that somebody has died and a pathologist has looked at their brain tissue under a microscope. That's not a very, very useful or efficient diagnostic modality. So when people are alive, we make probabilistic diagnoses. It's probably this, it's possibly that. And the information that we are getting now from blood tests has just leapfrogged progress. I mean, we have leapfrogged, I don't know what all we've jumped over, but we've jumped over lots of other tests that would be a lot more invasive, a lot more expensive, maybe even have radiation, not as simple as a blood test. We now have one blood test that is as good, this is big, as good as looking at cerebrospinal fluid. That's the stuff that you get out of a spinal tap. And probably as good as looking at special kinds of PET scans. That is one powerful little blood test. You may have heard that the FDA approved the first ever blood test for Alzheimer's disease back in early May, so just about 3 months ago. 4 months ago? 4 months ago. And this is called the LumaPulse blood test. It's actually a combination of two blood tests that have been around for maybe 18 months to maybe a little more than 3 years, 3.5 years or so. So now we put those two tests together, and that's the new LumaPulse blood test. And that test is as sensitive and specific. You don't have to worry about what those statistical terms mean. Just know that when you have high sensitivity and high specificity in one blood test or one test of any kind, that is a powerful test. And that is what we now have in Alzheimer's disease. Most exciting time of my career.
So we have a couple questions right here. Please, go ahead.
So at what age would you recommend starting the blood test?
Well, the question for the online audience is, at what age would we recommend getting a blood test?
It's not so much about age, rather it's at this time, and this probably will change in years to come, maybe months to come, but for the time being, it's about whether or not symptoms are present. So
symptomatic.
right, yes,
What
and
are symptoms?
yes, right. So at this point, we are the clinical practice guidelines instruct us that we should be considering getting that kind of testing when somebody is reporting symptoms. Now, if somebody has a strong family history, but they don't have symptoms, they may well want to know what their status is on this Lumipulse test. I'm contemplating asking my primary care doctor later this month to do it, and I'll just pay for it out of pocket. I don't think I have symptoms yet, but I'd like to know my risk, because the other thing that we know is that the pathology of a disease like Alzheimer's disease begins in the brain years, decades, plural, that's more than one decade, so as much as 20 years for the gradual accumulation of pathology. If I have that pathology accumulating in my head, I want to know so that I can even eat fewer potato chips.
So just to clarify, and I'll come to you in a second, at Sunday Health, we do order, as appropriate, not for everybody, but we do order these blood tests. There's more than one. This happens to be the one that has been FDA cleared. But these blood tests look at different types of proteins in your blood. So we order them, we interpret them. They're not difficult. This is why we're emphasizing them. If we ordered one for a patient, it would be as simple as going to wherever you typically go, a lab like Quest or like LabCorp, and just getting this particular type of blood test. So that's all we're talking about. Yes, ma'am.
I have two questions. One is whether insurance, specifically Medicare, pays for the blood test if
Yep.
there are symptoms, and what percentage of people who may be test positive will go on to get a dementia?
Yeah, great question. So the first question was, does insurance cover the blood tests, particularly Medicare? We at Sunday Health have had good experience with both Medicare and Medicare Advantage plans, commercial insurance plans, in getting these tests covered. I can't say 100% every patient, every plan, all the time, because as you know, in our system, there's always some exceptions, there's always some asterisks, what have you. But in general, we at Sunday Health have had good experience getting, with patients getting covered, particularly with Medicare. And now that the FDA has cleared this first test called Lumipulse, we're optimistic that there will be even more coverage for these blood tests. The second question was about what happens if somebody gets one of these tests, or in general, no matter whether it's with a test or without a test, gets a diagnosis. What next? Is that your question? No.
If they test positive on one of these blood tests or whatever the marker.
Oh, okay. Does that mean?
What percentage will go on to get a dementia diagnosis?
Okay, so if you test positive with a blood test, what percentage go on to get a dementia diagnosis?
So these blood tests, and I always quail a little bit inside, cringe, when I read in often the popular literature, the new diagnostic tests for Alzheimer's disease. That's a misnomer. There is no single test. I'm going to make an absolute statement here. There aren't very many absolute statements in medicine, but here comes one. There is no single test, one possible exception, that can make a diagnosis of any kind of dementia. And the one possible exception is an imaging finding in something called Creutzfeldt-Jakob disease, which is a rapidly progressive dementia that George Balanchine happened to have died from, but is very, very rare and really not relevant to anybody in this room. So for all of us, there is no test that can make a diagnosis of Alzheimer's disease or any other dementia.
A definitive diagnosis, right?
No, a diagnosis,
Okay.
period. A definitive diagnosis always requires tissue. When we order these blood tests, if it can't make the diagnosis, why am I ordering the test? Why am I making you go to the lab and get stuck? Because the information is very, very valuable. So when I am evaluating somebody, I'm going to look at the whole picture. And I want, if I'm making a diagnosis, I'm going to make a diagnosis based on what things are consistent with one another, what looks to be internally consistent, what maybe is not internally consistent. So there's now something called SNAP, Suspected Non-Alzheimer's Pathology. It's a new acronym, and what it means is, well, gosh, we have somebody here who has positive who looks like they have Alzheimer's disease, but all of their biomarkers are negative. Or, you know, something where the biomarkers and the clinical presentation of the person don't match. So we're coming up with these new things to describe these situations that we've never encountered before. We are learning as we go. Be patient with us, be gentle. But, so none of these tests can make the diagnosis. There is a school of thought that says that if you have a strongly positive Lumipulse test, the Lumipulse, which is 2 tests in 1, is not actually resulted in a single number. It gets resulted in what's called strata. So high risk, intermediate risk, or low risk of having excess amyloid, one of the proteins that goes rogue in the brain to cause Alzheimer's disease. If you have excess amyloid, that's what the Lumipulse test tells you the likelihood of whether or not you have excess amyloid in your brain. A high likelihood Lumipulse test means you probably have amyloid. A low likelihood means you probably don't. It's that intermediate group that we just really don't exactly know what that means yet. We know, too, that there are cases of people with positive blood tests, asymptomatic, and they've been, not clinically, but in clinical trials, in research, they've been followed for years. They don't develop symptoms. What do we call them? There's one school of thought that says once you have a positive biomarker, you have the disease. I personally do not subscribe to that school of thought. I find that to be a little bit overly deterministic, because I would find it very, very hard to say to somebody, look, I think you have Alzheimer's disease, when the person is completely asymptomatic. That's not something I want anyone ever to say to me, and I would not feel right saying it to other people. But there is a reasonable, rigorous argument that says that's what we should be telling people. There is another school of thought, and I might be more a member of this one, that says that we should be looking at things like biomarkers and blood test results as part of the bigger picture, and really, you know, looking at the whole person. And so then making a diagnosis that really sort of represents what's going on, not what might happen 20 years down the line.
So thank you. I see a couple more hands. If you would bear with me just one moment. I just want to get through one other very important topical area, and then we'll open it up for questions. So Amy, we're almost at the hour, so maybe we can just try to quickly cover this. And those are the 2 new FDA-approved drugs that I had mentioned early on. These drugs have been approved by the FDA within the last 3 years. One is called Leqembi by brand name. Dr. Sanders will give you the official names. The other is called Kisunla by brand name. These are both infusion therapies, meaning that you need to go sit in a chair, get an IV, and receive a drug. These are really exciting. They're not for everybody, and Dr. Sanders is going to explain that. Why do I say exciting? Because they're the first 2 new FDA-approved drugs that are disease-modifying drugs, meaning they're not addressing the symptoms of the problem. They're actually trying to address the underlying pathology. So maybe just a few words on Kisunla and Leqembi.
Yes, so these are called monoclonal antibodies. That's just the term that the mechanism for how these medications work. In order to be eligible for them, the eligibility determination is detailed. You must have either mild cognitive impairment or the mild stage of Alzheimer's disease. They are not for dementing diseases other than Alzheimer's disease. The underlying the MCI must be due to underlying Alzheimer's disease. You can have MCI that's due to something else, must be due to underlying Alzheimer's disease or the mild stage of Alzheimer's disease. And then you must not have certain other exclusionary factors. For example, you cannot be on a blood thinning medication because one of the side effects of these medications can be brain bleeding. So we want to be very, very careful. And these are the first ever, it's not just that they're new, the first ever in recorded human history, disease-modifying medications for a disease that causes dementia.
Thank you for that. So at Sunday Health, we can, through experts like Dr. Sanders, help you determine if you do have mild cognitive impairment, for example, and if you might qualify for one of these therapies. We can help you with that if that's something you're interested in. We partner with a group called Recognition Health, where they have an infusion center and they specialize in that. Recognition Health also happens to run clinical trials for MCI and Alzheimer's disease, so if that's something of interest as well, Recognition Health is our partner and collaborator in all of this as we look to be preventative. So we're at the hour. I just want a couple of little housekeeping things and we'll go to questions. I know a number of you are interested in the slides. If you registered for this event, you are going to receive a copy of these slides. And if you didn't register for this event and you want the slides, you can see our colleague Yuritsa, who's in the back, and she can make sure to get your email so we can send you the slides. Also, if you or anyone you know in your friend or family group would like to make an appointment with Sunday Health, we can also talk to you afterwards. You can just very simply go to our website. We'll present that information here. It's very easy to call us, make an appointment. We do take insurance, Medicare, Medicare Advantage, and commercial insurance. So just wanted to make sure I got that information out since I know some people might need to leave at the hour. Now, let's turn to questions. I know there's a couple hands in the room, and we also have some online questions. So if you see me looking at my phone, I'm reading the online questions. Yes, sir.
Dr. Sanders, under what circumstances would an autopsy be helpful? In other words, like if you have a family member that's passed away with dementia,
Can you repeat the question?
would an autopsy be helpful to make a diagnosis of, for example, one of those four?
Sure. So the question for our online audience is, under what circumstances would an autopsy be helpful? If you can find a neuropathologist to conduct the autopsy, an autopsy is always helpful. It is the only way to be sure of what was going on. And we're pretty good in life at making diagnoses now, much better than we were even when I began my career in 2008. But we're not perfect. And Alzheimer's disease is a tricky, wily little beast, and not everything that is Alzheimer's disease shows up walking and talking like an Alzheimer's duck. I apologize for the belabored metaphor.
I'm going to go over here and then come back. I see a couple over here. There was someone over here who had a question. Yes. Yes.
Where does dementia associated with Parkinson's disease fall on that?
Can you repeat that?
So yes, the question is, what about dementia? Try that again. Okay, there we go. The question is, what about dementia with Parkinson's disease? Earlier I mentioned dementia with Lewy bodies, and dementia with Lewy bodies and PDD, Parkinson's disease with dementia, are kissing cousins. And the only thing really that distinguishes between them is which came first and by how long. If the motor symptoms, which are typical for Parkinson's disease, show up first and by at least a year, and then later the person with Parkinson's disease develops dementia, which is not always, but frequent in Parkinson's disease, then we call that Parkinson's disease dementia. If cognitive or behavioral, and when I say behavioral, I frequently mean things like visual hallucinations and acting out the things you're dreaming about at night, which is not normal. Those sorts of behavioral manifestations or cognitive manifestations, if those show up first by at least a year, and the physical aspects of Parkinson's disease, what we call Parkinsonianism, come later, then we call it dementia with Lewy bodies. So dementia with Lewy bodies and PDD are really two sides of the same coin, or two ends of the same continuum.
Yes, I'm going to start here and then we'll come back here. Please.
Is Alzheimer's hereditary?
Sort of.
The question was, is Alzheimer's hereditary?
So there are certain genes that have genetic mutations, and if you are unlucky enough to have a genetic mutation, your destiny is fixed. You will get Alzheimer's disease. But most of the genetic impact, or most of the genetics in Alzheimer's disease, are not destiny-making genetic mutations. Most of them are related to risk enhancement. So many of you may have heard of the famous ApoE gene, which many people think of as the Alzheimer's gene. But that is a risk gene. It is not a destiny gene. So if you have one of the variants of the ApoE gene that increases your risk, that's all it does, increase your risk. Note to self, you might want to work on those modifiable risk factors if you know that you are at increased genetic risk. The ApoE gene is not destiny. And there are large research studies that have examined people who lived to be 95 years or older, had 2 copies, so the highest possible risk profile, smoke, drank, didn't go very far in school, cognitively intact. So clearly those people have some kind of protective factor. We just haven't found it yet, and boy, do I hope we bottle it when we do. So the short answer is kind of. But so if you have a first-degree relative, sibling, parent, that probably means that you are at a little bit increased genetic risk relative to somebody who does not have that kind of family history.
And would the blood test show that risk?
Not the Lumipulse test, but if we run your ApoE genotype, which we now do all the time. We used to not do that because there were no disease-modifying therapies. So the teaching was, don't get the genetic test because there's nothing we can do about it. And now that is all different.
Mm-hmm. We'll start there and then go to you.
I'm a question about vascular, cerebral small vessel disease. What causes it, and once it's there, what do you guys do?
Can you repeat?
Yes, so the question is about what is cerebral small vessel disease, what causes it, and what do we do about it? And cerebral small vessel disease, probably the vast majority of us have some degree of it in our brains because it comes from disease to small blood vessels, capillaries, arterioles, usually caused by the same things that give you heart disease: diabetes, high blood pressure, high cholesterol. That gives you disease to what we call the white matter. That's the cerebral small vessel disease. Cerebral large vessel disease, you know by another term. That's a stroke. If you have a large vessel that becomes a very, very small vessel, that's going to choke off the blood supply to a part of your brain. That gives you large vessel disease, a stroke. Small vessel disease, most of us have. The vast majority of people with Alzheimer's disease also have small vessel disease. And isolated Alzheimer's disease is actually a fairly uncommon, maybe even rare phenomenon, but in combination with vascular disease, very, very common. What is different about cerebrovascular disease is that it is now not a neurodegenerative cause of dementia. If it is widespread, it can cause a dementia, but not a neurodegenerative one. So if you can control your vascular risk factors, diabetes, blood pressure, sugar, you can prevent yourself from, or you can potentially prevent your cognitive decline from getting worse. What is different about the treatment of small vessel disease now compared to, I have to go back and look at when the guidelines changed, but certainly a decade ago, we used to prescribe aspirin, a baby aspirin. Pretty much, if you turned 50, somebody was going to start telling you, take a baby aspirin every day. We don't do that anymore. Those guidelines have changed. That's one of the great things about medicine. It's not fixed. We learn all the time. And one of the things that we learned was that there were more bleeding events from having all those people on aspirin than cognitive decline than we were preventing.
Thank you. I know you have, I'm sorry, can we follow up perhaps in the one-on-one after? Just, we're way over time and this woman would like to ask a question.
Have I understood it correctly that a person with Parkinsonian dementia would not qualify for the 2 new Alzheimer's?
The question was, would a person with Parkinsonian dementia qualify for one of the 2 new monoclonal antibody treatments?
And yes, you did understand that correctly. A person who has PDD or DLB would not be eligible for one of these new medications. They are for mild cognitive impairment felt to be due to underlying Alzheimer's pathology or mild Alzheimer's dementia.
So we're going to take 2 more questions, and then I have questions for you. So this woman, and then over here. Yes.
Yes, thank you. I was just wondering if my parents and my grandparents didn't have any kind of symptoms, any kind of cognitive problems at all. They just didn't have it. Could I still get it?
The question is if the parents and grandparents did not have symptoms of any form of dementia, could you still get it?
Yes.
Okay, yes, sir.
Yeah, thank you for a great presentation. The longevity centers sprouting all over the country, are they qualified to help with brain health, promote
I love this
lifespan?
question. The question is, are the longevity centers that are cropping up around the country qualified to help with brain health? And I love the question because it's relevant and also because it leads me into my questions for you. I think I'll give you my answer and then Dr. Sanders will likely want to add something, but I think longevity is one of those words that can mean different things to different people. And so a longevity center, I'm not sure we have a common definition in our collective understanding of what that is. In some places, there may be longevity centers around that have physicians, medical doctors like Dr. Sanders in the center, and perhaps they are addressing brain health and preventative cognitive care. I don't know. But I do think also there is a whole wave right now in our culture that is longevity more related to the non-medical or at least not traditional clinical factors that may have to do with some of the same things we talked about, like diet, exercise, et cetera. So in my view, I don't know that there's a common answer to your question that's well understood. I don't know if you'd like to add.
I think the only thing I would add is sort of caveat emptor. Let the buyer beware. There probably are some places that are not so good and other places that probably would be good. And I would say if you're shopping for one, find one that's not just going to do the diagnostics, but find one that's going to teach you what to do with the information that they give you, how to make yourself more likely to live longer.
I want to thank everybody for attending here and all of those who are online also. I want to thank Dr. Sanders for her fountain of knowledge, and I want to thank Sean and the folks at Inspire for this amazing setting, and thank you all again for attending. We'll stick around for a few minutes if you have some lingering questions.